Welcome back. I'm Dr. David Morwood. I'm a board-certified plastic surgeon, and this is Your Health television and radio program. Thanks very much for being here. And my next guest today, we're very delighted to have her with us, Dr. Arina Ganeles, oncologist. Dr. Ganeles, thanks very much for joining us.
My pleasure.
So, Dr. Ganeles, let's talk a little bit about your background and how someone gets to be an oncologist, which essentially is a cancer doctor.
Exactly. So, first of all, for me, it was not a hard choice of what profession to have in my life, to choose in my life, because in my family, everybody used to be a doctor. Some of them were MD, PhD, but majority of them were just MDs. And that's why it was not kind of even much discussed with me, but it was a natural choice to become a medical doctor. Because I was exposed to the discussions at home about clinical aspect of medicine and theoretical or scientific aspect of medicine, because my father was a molecular biologist. I think that it just happened to be in my life that I chose the most interesting specialty, which combines both aspects of medicine, theory and clinical part, and that's how I happen to be an oncologist. But the truth is that a lot of it happened by chance.
I see. So you come from a long line of not only
Yes.
doctors but scientists.
Yes, yes, you can say that.
So, Dr. Ganeles, you are an oncologist, which is a doctor who specializes in the treatment of cancer.
Mm-hmm.
So how does one get to be an oncologist? What's the training like for that?
So I am not only medical oncologist, I'm a hematologist oncologist. And I must tell you that it's quite a unique combination of two different specialties, and it's unique for the United States because in Europe and other countries like Israel, for example, hematology is completely separate specialty. And the only area which they kind of share with medical oncology is malignant hematology, meaning cancers of the blood. So in the United States, it just happened to be the case that we have training in both hematology, which is disorders of the blood, a specialty when they teach you how to treat not only blood cancers, but to recognize different aspects of the problems with the production of blood cells. And also medical oncology. Medical oncology is a science, or clinical science, which completely devoted to the diagnosis and treatment of cancer.
I see. So to become a hematologist oncologist, or what we used to call hemonc, the abbreviation in training, so you had to, of course, finish medical school, and then you did a residency.
You do internship, then you do residency, and then you do several years of fellowship. And I did 1 year of pure hematology and 3 years of medical oncology. So that's why it's a long way, but I think it's the most interesting specialty in the world, not talking about plastic surgery, of course.
Well, I must admit, Dr. Ganeles, it's great for me, and I know for you and our guests today, it's great that we love our work. I think it's much easier to get up and go to work if you love your job. So we're very fortunate. So again, so after residency, you did fellowships in hematology and oncology. And how long have you been in Monterey?
I came to Monterey in 2001 from Boston.
From Boston. Okay. Now, Dr. Ganeles, you know, I find in my practice and when I meet people that there's a lot of misunderstanding about exactly what cancer is. I mean, and there's so many types of different cancer. You mentioned that there can be cancer in the bloodstream. We've talked about skin cancer previously in these programs. You mentioned breast cancer, etc. So is it possible for you to define for the layman exactly what is cancer?
It's a good question, and there is no simple answer, but to try to make it simple, by cancer we mean uncontrollable growth of cells of a certain structure of the body.
Okay.
And by structure, I mean, it might be blood, it might be liver, it might be brain or skin.
Okay, so you mentioned uncontrolled growth of a cell. So the cell is the basic building block of our body,
is.
right? And no matter what structure we have, it's comprised of cells.
Of cells.
So the cancer is when that cellular growth is uncontrolled. Is that correct?
Yes, it's exactly right. But in addition to that, not all uncontrollable growth is cancer. But when we're talking about cancer, we mean that the mechanism which controls the growth is lost, and also this new structure, which might just slightly resemble the original tissue, develop the tendency to spread all over the body through bloodstream or through lymphatics. And this process is called metastatic spread. So this is a very important feature of a cancer. The interesting thing is that usually when people talk about cancer, they imagine a tumor, which they can feel, they can see either on a CAT scan or feel with their hands. And it's not always the case, because cancer sometimes doesn't have an appearance of a tumor. For example, cancer of the blood is just an increased number of certain blood cells which look abnormal. And that's what we call cancer of the blood.
Okay, so Dr. Ganeles, as for an example of something that's not cancer, sometimes in my office someone will come in, say, with a lump on their side or in their arm, and I can feel it, and it feels like a fatty tissue, and I can tell almost by feeling that it's something called a lipoma, which is benign. So what's the difference between a benign lump and a cancerous lump?
By benign lump or benign tumor, we mean a group of cells, or for example, fat cells, or fatty tissue, which resembles the original tissue which they originated from. It's just a lot of them. And they don't look really that abnormal. They don't have features of which we call malignant features. Not a lot of them or none of them are dividing. They don't have tendency to spread through blood vessels, and it's all confined to this organ where they originated from. On the contrary, the cancer, and again, cancerous growth can lead to either a tumor mass, or again, it might be a group of abnormal cells originated from this, from the certain structure of the body. And they just slightly remind the cells they originated from. For example, I will give you an example. When a person presents to emergency room with problems below the waist, meaning that all of a sudden a person became paralyzed and he can't move his legs. We do imaging studies. It might be CAT scan, it might be MRI, and we see big mass which originates from outside the spinal cord but pressing over the spinal cord. And we don't know. We just know that it's very bad growth, but we don't know what it is, where it came from, and how we should treat it. So then usually we do a biopsy, which is a CT-guided biopsy, and we take a little bit of tissue for further evaluation. And when pathologist looks under microscope, he or she can see that these cells remind the lung cells, the cells which originate from the lung tissue. So most likely this cancer came from the lung. So this is the example how tumor cells can slightly resemble or remind the cell of origin, where it came from. But it doesn't always look exactly the same as the primary tissue which it originated from.
I see. Now, Dr. Ganeles, you used a word, that word biopsy. Now, I know in my office, sometimes when I tell someone that they need a biopsy, they immediately get frightened because it implies that they have cancer, but that's not necessarily true. A biopsy is just a procedure to remove some cells so they can be examined under the microscope. Is that right?
Absolutely right.
So I know that one of your interests is the differences in gender, that there's some cancers that may or may not be related to estrogen circulating, and some cancers that may or may not be related to circulating testosterone. In other words, there may be differences in cancers according to gender between men and women. Is that true?
Yes, it's true. Just because I am not only a medical oncologist, but I am a mother, a wife, and a woman, I feel much closer to female patients. Doesn't mean that I feel distant from male patients, but I think I can relate more to the issues of women, which are either just diagnosed with cancers like breast cancer, ovarian cancer, endometrial cancer, or they're going through the treatment, or they're cured. But it just happened to be the case that now, when fortunately the breast cancer at this point of our life has lower incidence, and we will talk about it, why we think it's happening, but higher prevalence, and I will explain what it means, that women require more support after cure than probably during screening or even during the treatment. I think that we have to pay more attention to the patients who are done with treatment for breast cancer, ovarian cancer, and they need to get back to the normal life and to feel back to normal. And sometimes medical professionals underestimate the importance of that period of time. So what I mean by incidence and prevalence, what we know that since 2002, when the results of WHI, or Women's Health Initiative, study was published, everybody kind of realized that use of hormone replacement therapy can cause the increased incidence of cancer. So another way, hormone replacement therapy in postmenopausal women can increase the risk of a breast cancer approximately by 5 or 6% a year. And the risk goes up longer a woman stays on hormone replacement therapy. There is a little bit of difference between pure estrogen replacement and combined estrogen and progestin replacement therapy. But nevertheless, the risk of developing a cancer goes up. So since 2003, the incidence of breast cancer, or the number of new cases of breast cancer in the United States, dramatically went down. And it was announced in San Antonio meeting, which is an annual meeting of breast cancer specialists, that the new cases of breast cancers in the United States have decreased by almost 7%. And actually it was the reflection of the fact that physicians started to take their patients off hormone replacement. And that's what we see as a result of this intervention.
Okay, so Dr. Ganeles, for our audience, for our listeners and viewers, this is a very important issue. Now, just to summarize, so there are women who are perimenopausal or postmenopausal who will consider taking estrogen. Estrogen, that's a hormone replacement therapy, and it sounds like there's pros and cons. That could be a very complicated decision.
It is.
Now I know there are some advantages.
Absolutely.
And it sounds like perhaps there are some disadvantages. So could you summarize perhaps? I know we could talk about this for hours.
We can, and I would love to actually. But I think that every case and it's a big decision, should be discussed on individual basis, because I don't think that we should completely close the door on hormone replacement therapy. But I think that with time we will have more nuances which would evolve and will help us to figure out who is a good candidate and who is not. And let me give you an example. For example, a woman with severe osteoporosis, which is hereditary osteoporosis, of Asian descent, for example. And I will explain why I brought up this particular scenario. Should she or should she not be considered for hormone replacement, especially if she has, for example, a history of colon cancers in her family? And I think that in this case, we probably should consider hormone replacement therapy. First of all, hormone replacement is a preventative measure for colorectal cancer, and I don't think we should disregard it. Asian patients of Asian descent, they have very low incidence of breast cancer, much lower than in other groups, for example, such as Ashkenazi Jews. So the combination of severe osteoporosis, which probably would be a major factor in her quality of life, risk of fracture along the line, a risk of colon cancer, and relatively low risk of development of a breast cancer during her lifetime, probably would make her a good candidate for hormone replacement therapy.
I see. Well, Dr. Ganeles, that's fascinating to me, and I know we could talk about this for hours,
Yes.
And I appreciate you coming on the program. I hope you come back again.
I hope so too. Thank you for having me here.
Dr. Ganeles, do you have a phone number or a website or something we can give out?
Yes, I'm lucky to work in Monterey Bay Oncology.
Monterey Bay Oncology.
Monterey Bay Oncology. We are located in Ryan Ranch. It's 5 Harris Court, and phone number is 831-375-4105.
So that's Dr. Arina Ganeles,
Yes.
hematologist, oncologist, and you have a special interest in women and cancer. Thanks so very much for joining us.
Thank you for having me here.
I'm Dr. David Morwood. I am a board-certified plastic surgeon, and this is Your Health radio and television program. Thanks very much for being here, and I hope you come back again. So, that's fascinating to me. Now, what about the whole...